So good morning, everybody. Welcome to the plenary session 10, Innovation in Transplantation and Cellular Immunotherapy for MDS patients. My name is Nicolaus Kröger from Hamburg, Germany, and I'm happy to co-chair with Christian Chabanon here from the University in Marseille this session. So we have 4 presentations, and then we have 1 selected abstract, and all the discussions will be done at the end of the entire sessions. So I'd like to invite the speakers to stay in time. So this is 15 minutes, and for the abstract presentation, it's 10 minutes. So we have then a lot of time for discussion at the end. So it's my great pleasure to introduce first speaker, which is Professor Didier Blaise from Marseille. He's well known in the field in transplantation, especially in allogenic stem cell transplantation for older patients. And the title of his presentation will be Allogenic Hematopoietic Stem Cell Transplantation for Older Patients, a question of real personalized medicines. So please, Didier.
Thank you, Nicolaus, for your introduction. Hello to everybody. I'm very pleased to welcome you in Marseille and to talk about this topic. I have no disclosure really interfering with my talk of today. So the first question is, why considering allotransplantation in older patients, especially for patients with myelodysplastic syndrome? And in fact, I think you have the answer. Looking to the papers and to the publication made by your community, it seems very clear that you have been very nicely able to discriminate the different risk of the patients, going from the very low risk to the very high risk patient. And when you look to the outcome of this patient in one of the publications over the 2 last years, very clearly there is very few patients with a long-term cure that can be achieved. It's only the very low risk. And the majority of the patients, even if you look at 5 years, have overall survival under 50%. So in total, it's still an unmet medical need to cure the patient with myelodysplastic syndrome, whatever have been the recent developments. It's even worse when you look to the patient with an older age. Here are the patient above the age of 70 with no allogenic transplantation and only receiving hypomethylating agent. And you can see that the outcome is very dismal. Of course, I will not make the point about the patient above the age of 80, but if you look to the patient between the age of 70 and 74, you can see that the results are exactly the same. And this kind of patient can receive a more intense treatment. So at the present time, and despite new development over the recent years, we have not yet achieved the possibility of cure patients without intensive therapy. So, second question we may address is allogenic transplantation efficient in older patients. In fact, if we look to the analysis of results concerning allo transplantation in MDS and for older patients, there are many retrospective trials, but very few prospective trials. And I selected 3 of them just to make some point. First one has been reported by Marie Robin that will give a talk in this session. And it's a prospective analysis of more than 170 patients with myelodysplastic syndrome who had basically an indication of allogenic transplantation and no contraindication to the fact to carry out this transplantation. If you look to the result of this prospective study, you can see that the patients alive after transplantation are more numerous than the one alive without transplantation. What is also interesting in this paper is that only 70% of the patients have a donor available. It was only unrelated donor or matched sibling donor. And when they have an available donor, the transplantation was only carried out in 70% of the case, meaning that the first cause of failure of transplantation in this population is probably the fact that the patient had not referred to transplantation. Another study reported by Nicolaus Kröger on the stage, looked to the patient who were treated in the same way initially, receiving 5-azacitidine. You can see that the median age of this patient is around 63, 64, and the patient, after 4 cycles of treatment, were treated with allogenic transplantation if they have a donor, or they continue 5-azacitidine. And when you look to the result at the end of the day, basically the one who have received allogenic transplantation are doing much better than the other one. Another study on the other side of the Atlantic has been conducted with the same philosophy of biological randomization. And you can see for a patient a little bit older, median age around 67, that the one able to receive allogenic transplantation are doing better. So the point of these 3 studies for me is basically not to say that this treatment is better than the other one. It's just to say that we can achieve long-term cure for the patient after allogenic transplantation. Transplantation has changed over years. You know that it was started in 1957 by Don Thomas, and George Maté contributed a lot on this work. But over the 40 last years, many changes have erupted in the performance of this kind of treatment. I will not list everything, and I put some of them on this slide, but I will highlight 2 of them that I think are important. First one is the fact to use reduced intensity conditioning regimen with reduced toxicity, and it's opened the possibility to do transplantation in older patients. And the second one is the use of donor with an Haplo mismatch. And this will be covered by Nicolaus Kröger. And in fact, if you look to the impact of this change in transplantation, you can see that in my institution, it was really correlated to the increase in activity after we mastered these 2 parameters. And it conducted to a change, a real change in the population we transplant now in Marseille. If you look to the last bar here, you can see clearly that we are 30% of the patients we transplant presently are an age above 70, more than 50%, 40% have an age above 65, and 60% above the age of 55. So really is a change in the population we treat. In terms of donor also, it's very important. 60% of our patients receive a graft from a Haplo donor, and 30% from an unrelated donor. Very few for a matched sibling donor. So what are the good recipes to do allogenic transplantation? I have no time to do that, and I have no the answer neither. But I think some parameters are very important. First one is the conditioning regimen. Conditioning regimen is important because it allows to have an engraftment and perhaps also to treat partially the disease. So we address these questions 15 years ago in older patients. At this time, we consider patients with an age above 55 as being older patient, eligible for a matched sibling donor transplant. And we try to see what was the impact of what is now standard, this regimen, reduced intensity conditioning regimen based on fludarabine, IV busulfan 2 days, and ATG. And you can see here that, in fact, the results were quite promising with a low initial toxicity and with also the possibility to have a very good quality of life for the patient surviving after 1 year. So after that, we wonder, can we increase a little bit the intensity of the conditioning regimen, because the safety was important, but we probably lose some efficiency in the control of the disease. And in fact, we designed the randomized study that Régnier de Villiers presented 2 weeks ago at the BMT. In fact, we compared the outcome of patients receiving exactly the same conditioning regimen, except for the dose of busulfan, 2 days, 3 days, and 4 days. And it was a negative study because, in fact, we showed that when we increase the intensity of the conditioning regimen in this population, we increase the non-relapse mortality. And at the end of the day, again, the best results are achieved with the really reduced intensity conditioning regimen. And it's something we have to keep in mind, but older population is not the same as the other one. What about Haplo? I say Nicolaus will talk about that, but just to mention that we just performed this prospective randomized study of 2 strategies of transplantation when patients have no matched sibling donor. So the search for an unrelated donor or the search for an Haplo donor. And at the end of the day, we don't see any difference between the two groups, but it will be covered by Nicolaus. So over years, we have treated more and more patients with an older age, and over 20 years, we have treated more than 700 patients with this definition. You can see that the number of patients increased progressively over time. I've divided this period by 4 periods of 5 years, and you can see the median age of this patient also increased, being 67 now, and nearly 1/3 of the patient with an age above 70. 90% of the patients are treated presently for acute leukemia or myelodysplastic syndrome, and you can see that the vast majority of patients receive an Haplo donor and a non-myeloablative conditioning regimen. So at 10 years, results are not so bad, with a probability of survival of 50%, with no difference between the two groups according to the age. So among these patients, and I think it will be of more interest for you, we have treated nearly 160 patients with MDS of CMML. Of the very little characteristic of these patients. I collapsed the 2 first period because of the low number of patients, because you can see that majority of the patients were treated in the 5 recent years. You can see that, as I said, it's older population, 68, with 30% with an age above 70. There is 2/3 of the patients receive Haplo, and the non-myeloablative conditioning regimen represent 50% of the patient. When you look to the outcome of this patient, non-relapse mortality of 6 months is 40%. It's of course too much, but it's something appealing for this population of patients. What is interesting also is that the relapse rate is not so high in this population, showing that we can really control the disease. If we compare the result with the cohort of AML patients, no difference. If we look to the period, different period of time, except for the first period with low number of patients, you can see that we can achieve good result at the median and long term, and there is a plateau at the end. No difference between the 2 last cohort of period of the patient. Does it mean that we have not done any progress? No, because the population have evolved. As you can see, we are treating older patients with more Haplo transplant and less myeloablative or less intense conditioning regimen. No difference for the patient treated for CML, for MDS of CMML. And just a flavor of what we can do for what we consider really for the older patient. Median for the patient above the age of 70, treated for AML of MDS. We treated 51 of them with an Haplo transplant with an intent to treat prophylactic DLI. They all received the Baltimore regimen based on low-dose TBI and PTCY. Here are the characteristics. 48% of the patients were treated for MDS. And you look to the result at 3 years, non-relapse mortality, once again, too high, but think it's population of patients above the age of 70 with receiving an Haplo transplant. And the survival at 3 years is also around 70%. So results that I could not predict many years ago. And on the top of that, many of these patients really have no survive without any GVHD and without long-term immunosuppression. So how to progress now? In fact, we have to better know the patient we will transplant. We know, thanks to the work we have done, but much more about the disease the patient have, but we have to know much more about the patient. And we have many tools to do that. It's what we call the geriatric assessment, looking to the physical function, to the cognition, to the mental health, but other parameters as nutrition, social support, or on the pharmacy. And many of them are really predictive of outcome. And we have to perform a real comprehensive assessment of these different parameters. To contraindicate the transplantation? Perhaps, but usually we don't need this assessment to make a contraindication to treatment. It's rather to have an intervention prior to transplant in order to have a patient in a better shape at time of transplantation or even after transplantation to really keep the fitness of the patient, and at least some of them here. And for the patient who receives this kind of intervention, you can see on this curve that the one who receive it are really doing much better than the other one. So in conclusion, I would say, and I will take, in fact, this picture from Mohamed Sorwa in the issue of yesterday from Blood, when he tried for any kind of patient receiving allogeneic transplantation to show that we have many parameters we can use really to decide what treatment about the disease, about the patient, and the geriatric assessment you can see is here, or other parameters. So we have many tools we can use to do that. And it's really the possibility to do personalized transplant because we can accord the different possibility of treatment to these parameters. And we have not to forget that achieving cure, also it's a multi-step process. The pre-transplant treatment is very important. Transplant, of course, it is important. And the post-transplant treatment that will be covered by Marie is also something important. Each of these steps is important for the disease control, of course, but also to bring the patient in good situation to transplantation and also to have in good situation and good shape to receive post-transplant treatment, immunotherapy, or maintenance treatment. And that, we have to define these different treatments altogether. But on this word, I will finish my talk and thank the people working with me in Marseille, and notably Norm Hervé, who is now the chief of the Department of Hematology, and all the collaborators all over the world. And if you are interested in this topic of how to transplant older patients, you are very welcome to join us again in Marseille by the end of June for our 7th international meeting in Palais du Pharaon. Thank you.
Didier, we have question at the end, but you can join the podium.
So now it's my pleasure to introduce my co-chair, Professor Nicolaus Kröger, who is the head of the Department of Stem Cell Transplantation and Cellular Therapy in Hamburg, former president of the EBMT, and Nicolaus will speak on the importance of finding donors, in particular haplotype mismatched donors, and consequences for patients transplanted for myelodysplastic syndromes. Nicolaus.
Thank you, Christian, for the kind introduction, and thanks organizing the MDS community for inviting me to give you an update about haploidentical stem cell transplantation in MDS, and also to give some credits to allogenic stem cell transplantation at this nice meeting. So these are my disclosures for these presentations. So MDS is now becoming the second most frequent indication for allogenic stem cell transplantation, since the acute lymphoblastic leukemia, which has been the second most frequent indication, has now been, because of the new developments with CAR T cells, but also with immunotherapies, is now becoming the third most frequent indication. And the reason for this is that we transplanted now more older patients, as you have heard nicely from Didier in the previous presentation, but also, and I have to address this because the development in non-transplant approaches in MDS is much behind in comparison to other diseases like lymphoma and other lymphoid malignancies like multiple myeloma. So you can see this on this curve, and this is quite interesting because despite the fact that we are transplanting more older patients, the numbers of myeloablative in comparison to reduced intensity conditioning is quite stable. So currently we have about 50% in patients who received myeloablative and 50% who received reduced intensity conditioning within the EBMT registry. And you have heard this study already by Didier, and this is a comparison. So until more recently, we hadn't a lot of evidence base that allogeneic stem cell transplantation is a preferred treatment for patients with MDS. So this is a German study actually, but supported by EBMT, comparing 5-AZA after 5-AZA induction, 5-AZA continuous treatment to reduce intensity conditioning. And what you can see is there's a huge benefit for using allogeneic stem cell transplantation up to the age of 70 years of age. This was the indication. And interestingly, if you see, this is the event-free survival, this is the overall survival, you can see, of course, in the early period, you have a decrease in the Kaplan-Meier curve due to non-relapse mortality. But this difference is not so high as we see in other diseases, so strongly supporting the allogeneic stem cell transplantation procedures also in older patients. So when we look to so-called forest plots, you can see in all the different categories, you can see there is at least a trend favoring allogeneic stem cell transplantation in comparison to 5-AZA or 5-AZA continuous treatment. So the other large study, which has been also published recently, is the BMT-CTN study, also just presented by Didier. And they had just a donor, no donor comparison in the US. So they had 260 patients with donor and 124 patients without any donors. And also here, you can see the results were quite superimposable or identical to what have been seen in the European trial. So we have about 50% cure, 50 to 60% cure with allogeneic stem cell transplantation, in contrast to those who did not receive stem cell transplantation because they didn't have a donor. And also here you can see in the majority of the risk factors, you can see there was at least a trend, but there was, or it was significantly in favor for allogeneic stem cell transplantation. So what does it mean for us? So if you have, and this is Western world, this is US, you have at least in 1/3 of the patient, there is no available donor. That means that this category of patients, so this study was based on HLA-identical sibling and completely matched unrelated donors. So that means for our patients that at least 1/3 of the patient cannot achieve the curative treatment for this disease because there is no donor available. And I think we have to work on this, and the transplant community did this in the most recent years. And this was a previous work from Seattle showing how is the likelihood to find an HLA-identical donor in the international registries according to different ethnic groups. And this is an international meeting, so we have to address also people who are coming not from the Western world. So you can see here in Western world, so this is European, so we are quite luxurious because we can find in about 80% a suitable donor in the registry and unrelated donors. But if you look to other ethnic population, especially in Africa, Caribbean, and all around, you can see here in blue, the likelihood to find a suitable donor worldwide is less than 40, or in some ethnic groups, even less than 20%. And I think it's our duty to find also for these people or these patients a suitable donor or possibility to get curative allogeneic stem cell transplantation. So what are the options if there is no suitable donor available? So we have actually 3 different options. One is mismatch unrelated donors, so looking for HLA non-completely donors, cord blood transplantation, and more recently popular, the haploidentical stem cell transplantation. So the early work from CIBMTR, this is published a couple of years ago, compared matched sibling to matched unrelated to mismatched unrelated, and you can nicely see that the sibling transplantation still is the #1 regarding the donor choice, followed by completely matched donor. But you can see if you have a mismatched donor, there is a curative potential. However, this is less or significantly less than the complete matched unrelated donors. So within EBMT, and this was done by Marie, this work a couple of years ago, she compared cord blood transplantation in comparison to 10 out of 10 or mismatched unrelated PBSC transplantation in MDS patients. You can see best response for PBSC 10 out of 10. But if you have only a mismatched donor, you can see results became worse, and it was actually the most was worst in patients who had only cord blood transplantation. And this is reflected also to other diseases. And what you can see on this is the activity in Europe, but the activity worldwide or in CRBMTR is actually the same. So we have increasing numbers of stem cell transplantation from unrelated donors. We have increasing numbers of related transplantation. We have a decrease in using cord blood transplantation in transplantation, and we have an exponential increase of so-called haploidentical stem cell transplantation in all disease here in Europe, but this holds true also worldwide. Why is this the case? And there are some quite provocative data coming here. This is a retrospective comparison from China, suggesting in AML and MDS patients, especially those who are MRD positive, that sibling transplantation, you have in MRD positive a higher risk of relapse in contrast to patients who are MRD positive and received haploidentical stem cell transplantation, suggesting at least that maybe after haploidentical stem cell transplantation, the so-called graft versus leukemia effect might be more of interest. And the haplotransplantation historically was done as so-called T-cell depleted approach, mainly done in pediatrics. So this is quite time-consuming, is quite elaborative because you have to deplete T-cells from the graft. It's quite costly, it's complicated, and has not to become in clinical practice because we have also a lot of infectious complication and graft failure risk. So the field really moved forward with using so-called T-cell repleted approach. And there are two different approaches. One was developed in China. This is with ATG. This is anti-tumor-site globulin, so without any direct manipulation of the graft. And in the Western world, it was done by so-called post-transplant cyclophosphamide, which was developed by Johns Hopkins Group. And this is mainly done here in Europe and the US. And the idea of this approach is to give cyclophosphamide post-transplantation in a quite higher dose, so twice 50 milligram on days 3 and 4, and maybe to deplete, or let's say what we know nowadays is to modify alloreactive T cells to prevent infectious complications but avoid graft versus host disease. And with this, now we'll give you some clinical data, how this has developed in MDS. So this is data from the EBMT registry. It is already from 2017. So Marie compared here compared haploidentical stem cell transplantation in MDS in more than 228 patients. Either they received the so-called PT-Cy approach or received other approaches like T-cell depletion, for instance. You can see even if the patients were not well balanced or 100% balanced, but the most interesting results is that patients who received PT-Cy as GVHD prophylaxis had a lower non-relapse mortality, as you can see on the right-hand side, and this is translated in a better disease-free and overall survival, as you can see on the both curves on the left-hand side. So PT-Cy seems to be a good approach to develop haploidentical stem cell transplantation also in MDS patients. So consequently, the next step in the EBMT registry was, okay, let's see what is Haplo with PT-Cy in comparison to a mismatched unrelated donor, but also in comparison to cord blood transplantation. And this was done also by Marie, and this paper was published just recently, or you can see here. So the main point is that the so-called relapse incidence was identical nearly identical in all three donor sources. However, the non-relapse mortality was significantly higher if patient received cord blood followed by mismatched unrelated stem cell transplantation. And this resulted at the end, in this so-called alternative donor, that haploidentical with PT-Cy resulted in the best leukemia-free and overall survival in MDS patients in this EBMT registry study. So similar has been reported by CRBMTR. This is the corresponding registry from the US. But here you can see they compared with completely matched sibling transplantation, unrelated donors and haploidentical stem cell transplantation. And what they found was a bit surprising. They had a higher risk of relapse using haploidentical stem cell transplantation compared to 10 out of 10 matched unrelated donors. But matched unrelated donors resulted also in a higher non-relapse mortality. So this was a bit surprisingly. But at the end, you can see this is the overall survival. So haploidentical stem cell transplantation and completely matched unrelated donor seems to be at the overall survival nearly identical. And this is quite good news for our patients. So what EBMT did next, and this was also from the Chronic Malignancy Working Party, published just recently, they compared then haploidentical stem cell transplantation to sibling transplantation. So you can see the number of sibling transplantation was much higher, with more than 1,400 patients. You can see the age was a bit different, so the age from the donor especially was younger in the haploidentical stem cell transplantation. There were also other not complete balance between risk factors. But the most interesting result here is that sibling transplantation seems to be better regarding non-relapse mortality. This is what we expected. So at the end, sibling transplantation still is in favor, in contrast to haploidentical stem cell transplantation in MDS patients. So clearly showing that the sibling transplantation is probably still the donor of choice if there is an HL-identical sibling available. So a small study just recently published by the French community here, they compare as well Haplo versus MUT and HL-identical sibling. You can see the numbers were much smaller than from the EBMT registry. And here, surprisingly, you could see that matched unrelated stem cell transplantation was in favor in comparison to Haplo and sibling transplantation. But if you divided the donor, the unrelated donor according age, you can say younger age was more of importance if the donor was younger than 30 years in contrast to older. So age is also very important in selecting the donor in Haplo and in matched unrelated donor stem cell transplantation. So this is a bit confusing just to see the multivariate analysis, and you can see if you put all the different donors in the multivariate analysis regarding non-relapse mortality, overall and leukemia-free survival, there was actually no difference regarding the different donor sources. Coming back to the age and maybe also how to select the optimal donor in haploidentical stem cell transplantation. So I would like to focus first on the right-hand side. So if you have patients who are in the age 18 to 50, so younger patient, you can see it doesn't matter whether the donor is younger or older. However, if you have older patients, 55 to 70 years of old, so this is more for the MDS cohort of patients, you can see the donor age has impact in haplotransplantation. So the donor, if the donor is less than 30 years of age, the outcome becomes much better. While if you look here to the different age categories, and the degree of relative, whether this is first degree or whether this is second degree or offspring donor, there was actually no difference if PTCy was used as GVHD prophylaxis. So maybe this is then becoming a bit more complicated into more different phases. So if you have haplo donor, depending what kind of haplo you are using in transplantation, whether the strong T-cell depletion, the T-cell repleted PTCy approach, or the T-cell repleted ATG approach from the Beijing group, you can see there are several factors which are not completely concurrent between all the different approaches. However, the most important, this is the reason why I show you, is younger age is always in all categories, is also very important to predict a favorable outcome in this patient. So I think, and you have seen this also by Didier, so I talked only about stem cell infusion and using the graft source. However, the transplant procedure has so many different variables and factors which impact the outcome. So it's always very difficult to focus only on one. I focus only here on the donor, but we have the pre-treatment, the conditioning, GVHD prophylaxis, and relapse prevention, which we will have very soon. So, but regarding the donor, and I think this is the good news, and I will cite the most recent paper, which we published just recently from the American Society of Stem Cell Transplantation, Cellular Therapy, regarding hematopoietic stem cell transplantation in MDS. So this is a worthwhile paper to read, is open access in the journal. And but regarding Haplo, so this is also my main message. Also, high-quality evidence is still lacking. We are currently recommend that haploidentical donors and mismatch unrelated donors can be considered the preferred donor options for patients lacking an HLA-matched donor. This is grade C, level 2-1. In aggregate, so if we see all the data we have presented also here, the accumulated data suggests that haploidentical related donors may result in superior outcome. I think this is good news for our patients. And with this, I want to close my presentation and thank you for your attention. Thank you very much.
Thanks so much, Nicolaus. So we'll take all questions at the end. And thank you. So the session is to be concluded by two selected oral presentations, but I just check that Dr. Fernando Barroso Duarte is not here, was not able to make it from Brazil, and speak about the Latin registry. So if not, we'll move to the final presentation that will be delivered by Dr. Ayman Sayed, I hope I say it properly, from Toronto in Canada, and who will describe his work with optimizing the conditioning regimen for patients with MDS. Thank you.
Good morning, everyone. I would like to thank the organizer for accepting this abstract. My name is Ayman Sayed. I'm a clinical fellow at Hans Messner Allogenic Stem Cell Transplant, Princess Margaret Cancer Center. I'll present our experience in the use of triosulfan plus fludarabine, reduced toxicity conditioning, in combination with dual T-cell depletion in MAC-ineligible patients with MDS. So this is our disclosure. Sorry, this is the photo of Ivan Basic. He's the principal investigator, and he was supposed to present this talk, but unfortunately he couldn't make it. This is the disclosures. So triosulfan is an alkylating agent that's similar to busulfan. There are many retrospective studies that have looked to the outcomes of using triosulfan in the AML and MDS setting. Most of them with very few number, but actually they reported very good outcomes in MDS patients. Actually, the result reported in these studies are much better than what's reported in CIBMTR. There is only one prospective study that was published in 2020 that compare fludarabine triosulfan to busulfan fludarabine, and again it showed significant superiority of triosulfan-based conditioning regimen in overall survival and lower transplant-related mortality. There's one retrospective study reported in 2017, and it did show some significant lower relapse by using triosulfan, but again, this reported in 11 patients with MDS. So the aims of our study is to study the effect of triosulfan on the 1 year overall survival, 1 year transplant-related mortality, and cumulative incidence of relapse. Secondary endpoint, where day 100 acute GVHD, grade 2 to 4, and grade 3 to 4. 1 year chronic GVHD, all grades and moderate to severe. Day 100 event-free survival, and actually we could report it day 100 only because of short follow-up. 1 year relapse-free survival, and 1 year GRFS. It's a retrospective study. We identified 87 adult patients who underwent allogenic stem cell transplant at Princess Margaret Cancer Center for MDS and CMML between 2015 and 2022. We identified 29 patients who had received triosulfan-based conditioning regimen, and 58 patients in the control arm who received fludarabine, busulfan, and TBI of 200 centigrade. The control group was designed using propensity score matching based on the diagnosis, whether MDS versus CMML, age less than 65, more than 65, HLA typing, post-transplant cyclophosphamide, HCTCI, and disease risk index. To be mentioned that 92% of the participants were received in vivo dual T-cell depletion with ATG and BTCY. So from 2015, we used ATG, BTCY, cyclosporine as GVHD prophylaxis in all of our haploidentical and match and related donor with different doses in ATG, 2 milligram per kg, in match and related setting, and 4.5 in haploidentical setting. So this is the protocol. In the upper part is our RIC protocol, is fludarabine, busulfan, and TBI 200 centigrade. It's 4 days fludarabine, 2 days busulfan starting from day -5, plus TBI 200 centigrade day -1. In the lower part is the fludarabine triosulfan protocol. It's composed of 4 days of fludarabine and 3 days of triosulfan with different doses, 10 or 14 gram per meter square. And the choose of dose is based on the MRP decision, and this mainly by the age of the patient, comorbidity, and frailty. This is the patient characteristics. There is no difference regarding the age, diagnosis, donor type, GVHD prophylaxis, the use of dual T-cell depletion, DRI, IBSS, HCT-CI, or KBS. But there is significant difference. There are more female patients in busulfan arm, and the patient in busulfan arm also had received higher CD34 doses. Also, I want to highlight that almost half of the patient here has HCT-CI of 3 or more, and almost a third of the patient with KBS of less than 90%. Here are some of the results. Regarding the hospitalization, there is no difference in length of stay, immunosuppressant discontinuation, or platelet engraftments, but there is faster engraftment in busulfan arm, and this could be explained by higher CD34 dose in this group. Regarding the length of stay in the readmission setting for the patient who discharged after transplant and readmitted within the first 100 days of transplant, there is significant difference in the length of stay. 11 days in busulfan arm versus 4 days in triosulfan arm, with very significant p-value. Regarding the survival at 1 year for triosulfan arm, 83% versus 53% in busulfan arm. And this benefit was confirmed in univariate and multivariate analysis with hazard ratio of 0.19. There is significant lower non-relapse mortality in triosulfan arm with almost 8% versus 33%. And this was also confirmed in the univariate and multivariate analysis with hazard ratio of 0.21. For the relapse, there was no difference between the two groups. No differences in acute GVHD or grade 3 to 4, and no difference in chronic GVHD. For event-free survival, we define the events here as either death, relapse, acute GVHD, grade 3 to 4, severe chronic GVHD, infection, or grade 3 to 4 hemorrhagic cystitis. So there's a better event-free survival in the triosulfan arm, and this was confirmed in univariate and multivariate analysis with hazard ratio of 0.51. Relapse-free survival, 76% in triosulfan arm versus 42% in busulfan arm. And this was confirmed in multivariate analysis with hazard ratio of 0.26. The same thing in the graph GRFS, 72% in triosulfan arm versus 37.9 in busulfan arm. And again, this was confirmed in multivariate analysis. To conclude, triosulfan-based reduced toxicity conditioning was associated with improved overall survival, transplant-related mortality, event-free survival, relapse-free survival, and GRFS in a cohort of MAC-ineligible patients with MDS, and this was confirmed in multivariate analysis. So it's a reasonable option for this group of patients. And as we know, the MDS patients are elderly with a lot of comorbidities. So most likely, most of the patients here are ineligible for myeloablative conditioning regimen. Now, we think that these benefits mainly driven by lower transplant-related mortality and non-relapse mortality in triosulfan arm. There is one study, as I mentioned, it's a retrospective study that did show lower relapse in triosulfan arm, but with a few number, only 11 MDS patients, but they used higher dose. They used 42 grams per meter square. In our study, we used about a third of our patients did receive the reduced dose. It's 30 grams per meter square. So this is why we may not get the significant p-value here. Again, this retrospective study with a small sample size, definitely larger study are warranted. I want to highlight that this is the first study that reports the use of triosulfan conditioning regimen in the setting of in vivo dual T-cell depletion with ATG-BTCY with encouraging results. Larger prospective study are warranted, and it would be of interest to look to the immune reconstitution, especially in our setting when we used a dual T-cell depletion. Thank you.
Thank you. So will you join us? And I think we'll start the questions and answers. Nicolaus, you start.
So we have now time for about 15 minutes for discussion. So if you have questions, please come to the microphone, identify yourself. So from the audience, we so far have no questions. So maybe I can start with Didier. So how would you select now patients for transplantation, MDS patient? What is in your department the indication, let's say, for older patient 70 plus?
The idea is, why I try to explain that, in fact, in many cases, there is no real choice concerning the outcome of the patient is very poor if we don't do transplant. So the idea is not to contraindicate the transplantation, but really see with the people in charge of MDS how we can go to the transplant for this given patient. So all the parameters, we are now conducting geriatric evaluation for all the patients, and this geriatric evaluation will allow us to, for example, increase the physical activity, increase the nutrition, improve the nutritional status of the patient in order to have a real fit patient at time of transplant. Afterward, we try to do the same thing after transplantation because I do think it's very important. And the final point is that we choose to have non-myeloablative regimen for this patient, even if the toxicity, even if the activity against disease is lower, because we will deliver some treatment afterward, and notably DLI.
There is a question. Please identify yourself. And
yes, this is Hua Liu. I'm from Shanghai. I am so excited to attending this last session and for the transplantation versus cellular immunotherapy. But I feel a little bit imbalanced because we have heard a lot about the transplantation and heard much less than the immunotherapy. Also, of course, we mentioned the donor lymphocyte infusion. And also we mentioned the CAR-T And we all know CAR-T has been approved and with very excellent results for the B lymphocyte lymphoma or leukemia. And I just would like to share some of our experience for the immunocellular therapy. As I mentioned at first day at the meeting, and we treat some patients with MDS using the cytotoxic T lymphocyte. We achieved excellent, remarkable clinical results or response. And very briefly, the hemoglobin can increase from 48 grams to after treatment to 183. And the results are long-lasting. We can achieve more than 5 years complete remission. So also with very good safety profile, no GVHD, no CIS, no autoimmune disease.
You
So I
have
think
a-
this is
You have a question to the podium as well, or only
Yeah.
present your data?
No. I'm just want to share because I think the immunocellular therapy in this area is important. Now, of course, also I have a poster here, 138, and I believe this is the important area we need to pay attention to. And so I just want to say my question is, I think that the immunocellular therapy in the MDS area is still very promising. Of course, our experience are limited in the trisomy 8 patients only. So I would like to, just appeal to the research scientists and the clinical physicians, and maybe we need to pay attention to this area, maybe see the other opportunity to the other subtype of group of MDS patient. My basic point here is I do think and that transfusion or using the immunocellular therapy should be something we pay more attention to. Thank you.
Thank you.
Thank you for your opinion. Other questions?
I have a question to Marie, if possible. So, Marie, you mentioned the different maintenance therapy, and you mentioned also the, let's say, the frustrating 5-ADA study. So, what is the future of maintenance therapy in MDS patients if you consider also the new agents which are more anti-leukemic, like venetoclax?
So even if this phase 3 trial was not so encouraging at the end, I think that there is a room for the maintenance therapy, especially with the use of some specific treatment, maybe in specific patients, meaning that we can in the future design some personalized therapy in MDS patients. So we have to wait for the phase 3 trial, of course. But possibly that's not the same if we speak about very high-risk MDS patients and standard risk. So I think that in very high-risk patients, they may have really a benefit of the maintenance therapy, and specifically hypomethylating agent and venetoclax, for instance. And I have a question also for
First, and then you please identify yourself.
Yes, Eva Hellström-Lindberg from Stockholm. Oh, here we go.
Now we see you.
So I would very much like to ask a very open question. I mean, venetoclax is a strange drug. It sometimes helps magnificently, sometimes it doesn't help at all prior to stem cell transplantation. But according to my understanding, apart from acting on potential tumor remaining cells, it has also a toxic effect on the T cells. So could someone among the podium speculate on pros and cons of using venetoclax post-transplant and the risk of actually deleting a graft versus leukemia effect? I may be wrong. I'm just curious because I think there are conflicting evidence.
I think you're right. I think from venetoclax it's too early to discuss maintenance therapy, especially in MDS patients. I mean, the drug is quite myelotoxic, so we see, especially early after stem cell transplantation, we should avoid drugs which can cause severe cytopenia. And regarding the graft versus leukemia effect or graft versus MDS effect, we see this also with 5-ASA. So 5-ASA is actually an immunosuppressive drug. Yeah, it's very immunosuppressive, so it increases regulatory T cells, and in models you can also see it decrease anti-leukemic effect. So therefore, probably Marie didn't mention this, but in relapse patient there is the combination using 5-ASA plus DLI is probably more effective than using only 5-ASA, if I'm correct, Marie.
Okay, thanks.
Marie? Oh.
If I may, I just have a question for Nicolaus. So honestly, now regarding the type of donor, do you think we should propose Haplo identical donors for all MDS patients who have no HLA match donor, or do you still have some reserve for some specific patients?
So in general, since I'm now looking to the field of MDS for many years, so I'm still very convinced, and this is really my personal opinion, we do transplant to less patients with MDS. Yeah. So the MDS still is, especially high-risk MDS, is a horrible disease. It's really nothing really which can prolong survival, maybe 5-ASA with 1 year. And if you look all the data we have so far, and both studies have shown it, or 3 studies, Marie's studies, the German studies, and the BMT-CDN study, has clearly shown transplant for older patients or for high-risk patients is of benefit. And since we have now also the options of Haplo, and the data so far, it's not very evidence-based, but Haplo is suggesting, at least what we have today, have similar outcome like match unrelated donors. Even it's not, so we have ongoing randomized studies in AML, not directly in MDS, but we have ongoing studies. But I think this is a really good option. It's also a good option for those countries who have less resources, because it's with using PTCy. You will have in every family most likely a donor, which is more or less for free. You don't have to look for unrelated registries. And from all the drugs we have so far in hematology, which are so expensive, so yesterday we heard about luspatercept, which is so effective in some patients with anemia, but it's not available in all countries. So PTCy or cyclophosphamide is available in all countries, and it's quite very cheap. So I think this is really something where I would encourage the MDS Society to push this more, because this is still a curative treatment approach, even in older patients, 70 and plus. So if you look, for instance, to the what happens in the last 20 years in countries like Europe or US, so in the median survival of patients with 70 years of age is nowadays 15 years. So if you have a patient today, or let's say in the general population, people who are 70 years of age, the life expectancy, the median life expectancy, is still 15 years. Yeah, so that is, they will lose anyway. Whatever you do for MDS, they will lose life years. So there is an option. It does not mean everybody should be transplanted, but there are also patients with life expectancy with 20 or 30 years of age. So we really should think about more transplantation. This is actually my main message.
I may perhaps comment on one of the questions that had been asked, because I do think really that the post-transplant treatment and period is very, very important. In fact, it's a place where we can be successful for this kind of patient we want to treat. And there is no room at the present time for these older patients for a standard, what we call a standard treatment, a standard transplantation as we did before. We have to be very innovative. And venetoclax or 5-azacitidine have backside, that's true. DLI have backside also. But we have really to evaluate this situation. And if I take the example of DLI, we have now large experience in this situation We have more GVHD after DLI for sure, but we have very low rate of death related to this DLI-induced GVHD. So we have really to try to configure the transplantation in another way, taking the first step of transplantation only as a platform to deliver more treatment.
May I? So just for you, and so the incidence of relapse for MDS is about 25 to 30% if you have all patients. So in other words, if we treat patients prophylactically, we treat a substantial number of patients for nothing because they wouldn't relapse anyway, and we treat also patients who will relapse despite the therapy. So I think before we go into the general recommendation of prophylactic therapy, we need better biology of patients who have a high risk of relapse and those who have a lower risk of relapse, and we need also more prospective studies or randomized prospective studies who suggest it, as we have done for many years in breast cancer or in other solid tumors.
Yes, and there is also the role of the preemptive therapies based on MRD. So in this case, we don't have a randomized study, but that's true that we know that this patient will have morphological relapse at the end. So we just have these two phase 2 trials telling that it's feasible and well tolerated to start failed ASA on MRD. So I think we should also put many efforts to develop standardized MRD to schedule preemptive therapies.
Maybe a question to Ulrike and next generation cellular therapies. So you rightly pointed out to the fact that we don't have a good tumor antigen in this group of disease. Do you believe there may be an indirect approach to target the microenvironment that plays quite an important role in the disease?
For sure, it's too early to answer that, but the preclinical data now with combining 2 or 3 or 4 monospecific CARs and with a safety switch that you can get rid of them if you want the hematopoiesis start growing again. This looked very promising, but it's for sure only preclinical data, and so it's too early. But I think this is the way to go.
Maybe a last question to Dr. Syed. So thanks for your nice presentation and the encouraging results. So you used in your trial ATG and PTCy, and usually this is more theoretically because PTCy is thought to maintain the alloreactive T cells post-transplant, but you used ATG quite close to the transplant I saw on day -3, -2. So therefore, because of the long half-life we have with ATG, you probably deplete all the T cells also on day +3 and 4. So did you consider this while planning the study?
Well, this is the routine protocol for all of our patients. So all of our match and related donor and haploidentical donor received ATG BTCY. This routine, not specific for MDS patient. And actually, till now, we don't have much significant graft failure or disease relapse. So when we compare the old data, the old patient who did not receive this to our dual T-cell depletion, we have similar relapse rate, no much difference in graft failure, but very good control, especially of chronic GVHD. And we have a poster that discussing the dual T-cell depletion in this setting. It's poster 136. So very low, moderate to severe GVHD, almost 8%. Very low acute GVHD, grade 3 to 4, with almost similar relapse rate. Yes, we need longer follow-up to see the impact, the relapse, the more if there is any significant relapse. But again, we did not notice that. And we use very small dose of ATG in the match and related donor. It's only 2 milligrams.
Okay, thank you. I think, Christian, if there are no further questions from the audience, we are just in time. Will you close the session?
Definitely. Well, we would like to thank all of our speakers, thank Nicolaus for co-chairing this session with me, and thank all of you for attending. And please attend the final session of the meeting and return home safely. Thank you.
Thanks, Christian.